Welcome, everyone. My name is Olivia Allen, and I have the pleasure of being part of Landmark Ventures, host of the Social Innovation Summit. A very warm virtual, great seeing you again to our Social Innovation Summit community. And for those of you who might be getting to know us for the first time, welcome. The Social Innovation Summit is a platform designed to elevate groundbreaking ideas and innovative leaders who are changing the world for better. Throughout the year, we are honored to partner with organizations doing trailblazing work within our society to amplify conversations and explore solutions to the biggest issues of the day. One of those incredible partners is the American Medical Association, or AMA. Over the past several years, there has been an increased awareness of the exclusionary policies and practices that have restricted and impacted the healthcare innovation ecosystem for communities that have been historically marginalized and minoritized. These historical truths warrant restorative remedies to heal and reconcile past and current harms. Today, you are joining Social Innovation Summit and the American Medical Association for the third virtual session of the Prioritizing Equity Spotlight Series. The incredible experts joining us today will be in conversation around applying a restorative justice lens to the healthcare innovation. Our speakers will explore policies, practices, and strategic opportunities to center healing and humanity in healthcare design and technology. Now, we are just about to get started, but a bit of housekeeping first. We've sent all attendees a digital brochure with speaker bios and the agenda for today, and we will be taking questions from the audience that our panelists will answer towards the end of the discussion. So please submit your questions for our panelists throughout the Zoom Q&A function. And now I am so pleased to welcome an incredible leader within the American Medical Association and a very dear friend of the Social Innovation Summit, Dr. Aletha Maybank, the Chief Health Equity Officer and Senior Vice President for the American Medical Association. Dr. Maybank, over to you.
Hi, I'm Dr. Aletha Maybank, a pediatrician and preventive medicine and public health physician, and the Senior Vice President and Chief Health Equity Officer for the American Medical Association. I'm happy to welcome you to the third Prioritizing Equity Spotlight Series entitled Centering Restorative Justice in Health Innovation, a timely conversation about structural racism and reckoning with past harms and what we should do as it relates to health innovation. I'd like to thank the American Medical Association Foundation, the Robert Wood Johnson Foundation, and Social Innovation Summit for supporting this work. The COVID-19 pandemic and the public murder of George Floyd brought an increased awareness to not only the general public, but as well to the public health and medical communities about the impact of health inequities and the historical and contemporary policies and practices that often leave founders and health founders who identify as women, Black, Latino, Indigenous, those who identify as disabled, and LGBTQ+, often left out of receiving capital and support to launch their solutions. These historical truths warrant restorative remedies to heal and to reconcile the past and current harms and to advance equity. In this conversation, we will explore critical realities and opportunities that center healing and humanity in health innovation design and provide some insight on how you and your company can advance health equity through accountability and restorative justice. Thank you for tuning in, and I hope you find this discussion meaningful.
Hello. Thank you so much, Olivia, for that amazing introduction. I want to just acknowledge our partners at the American Medical Association, Dr. Maybank, and just share how delighted I am to moderate our time together. As Olivia mentioned, we do want to encourage active Q&A, and so please do feel free to send questions along. We'll take maybe about half an hour to go through a little bit of a dialogue that we had kind of discussed up front, and then we'll accept your interactive questions and make sure that we have a fun discussion. If I may, I'll take 1 minute to introduce myself. My name is Klein. I'm the founder of the Social Innovation Summit and also CEO at Landmark Ventures. And I'm joined by 4 amazing panelists. It's really just an honor to be here. In our time today, I want to go through kind of 3 or 4 parts. We'll begin at the top, really thinking about some of the problems around systemic health and disparities. We'll then move into restorative justice and intersectional innovation, contextualize that in the context of the Full Health Initiative, and lastly, end with a dialogue around some solutions, ideas, and opportunities. And so with that, I'm going to ask each of the panelists to briefly introduce themselves in no particular order. Ivelisse, if you don't mind, perhaps you can get us started. Excited to hear a little bit about you and your background as we commence this great discussion.
Of course. Hi, everyone. It's an honor to be here. I'm Ivelisse Andino, CEO and founder of Radical Health, where we get to have meaningful conversations that are actually using restorative justice circles. I'm a trained restorative circle practitioner, and get to really apply the idea of circles and conversations to healthcare, as well as helping folks navigate the healthcare system on their terms, where they can know their rights, know what questions to ask before, during, or after a visit. I bring my professional experience that I get to do every day with really just living through a lot of the things that we see. Home for me is the Bronx, New York, and a lot of things that I grew up seeing and that I still see kind of influence my work at Radical Health, and really committed to the idea of a future and a new way of doing health and healthcare that really centers the folks who have been the most impacted.
Wonderful. That was a great introduction. Kapima, if you don't mind, KP, if you could kindly provide an introduction from your side.
Wonderful. Thanks so much. Yeah, so my name is Kapima Yopala. I go by KP. I'm the co-founder and CEO of In-On Health, and we're on a mission to better connect multicultural populations to care, specifically using the appropriate types of communication channels to better get them connected to the services they need. And we work with payers, health systems, and some pharma. But in terms of my broader background, I'm a bit of a serial entrepreneur. So the first company I founded was actually on the African continent. My family is from Ghana. I was born in the US. And our company has worked in 13 different African countries doing similar work. My chair of that business is today. It's still operating primarily in Southern Africa. And last but not least, I chair the Colorado eHealth Commission, which governs all health IT in the state of Colorado where I live. And we have an intentional focus around digital health equity and inclusion. Really, it's a pleasure to be here. Thank you.
Wonderful. Thank you so much. Dr. Tony, if you don't mind, perhaps you can go next.
No, absolutely. Hello, everyone. My name is Dr. L. Tony Lewis, and I am a Black woman and proud multi-hyphenate. I am a family physician and geriatrician, a creative, a dancer, a labor leader, political strategist, but really just a multi-hyphenate in these streets who founded Liberation Health Strategies to kind of gather up my tribe of folks who work across all of these industries to create as many spaces as possible for like liberation at the fullness of that, like feeling free beyond free, right? At the local level, I like to say streets to suites. I do work locally, individually, deliver babies occasionally, and globally with my folks around, tribe around the globe working towards health equity and freedom and imagining dope things. And excited for this conversation today. In Bed-Stuy, Brooklyn. You can see the crown molding of like a brownstone kind of in behind me. But yeah, Bed-Stuy, Brooklyn is where I am.
Very nice. And I think to the multi-hyphenated, we need to add poet as well. So just make sure that we add that to your bio. Catherine, if you don't mind, perhaps you can finish off our panel, introduce yourself as well, please.
Sure. Hi guys, Catherine Cooper here. I'm currently based in Los Angeles. I'm happy to be here with all these lovely individuals on the panel. Right now, I'm representing Health Tech DEI, which I founded with my colleague, Dr. Juan Espinoza. We bring DEI to investment strategy through lived experience. Specifically, we work with capital allocators around strategies that optimize financial performance and capitalize on the wealth and diversity, exclusively in the health tech space for now. And we're working with the AMA on their Infill Health Initiative, running some workshops for capital allocators and how they can better think of supporting health innovation, whether that's kind of diverse founders or diverse fund managers. On my other time, I'm a venture capitalist at Jumpstart Nova and a partner investing exclusively in Black founded and led healthcare companies. So it's fun to tell folks about that strategy, knowing that I do that myself. But I'm excited to learn from all the other panelists and be here today.
Wonderful. Thank you so much. So what an amazing panel, what diversity of backgrounds and ideas and perspectives. And so I'm really thrilled to dive in. Something that I've learned in my life and in my career to understand where we're going. Perhaps we need to understand where we've been. And I'm wondering if anybody wants to field an open question just to get us started. I think that, it maybe goes without saying that there are systemic health disparities in this country and around the world. I'm not certain if everyone who's listening in maybe is aware of what that actually means, what that entails, either what that looks like at a macro or what that looks like at a micro. And so perhaps someone can just step in and share a little bit about what the problem is, kind of what is this, what are we up against, kind of what does the system look like today? And from there, perhaps we can move a little bit to what are the changes that we'd like to see?
I can take this and don't, I guess, completely quote me on these numbers. I'm not 100% sure if I'm going to get my percentages completely correct, but I'm going to use an analogy that is not my own, but the Chief Medical Officer of United Healthcare Group told me in a conversation about health equity, and I thought it was very, very telling. So I think a lot of times the Black maternal healthcare outcomes comes up as a blaring example of inequities across racial lines. And instead of saying, Black women are 4 times more likely to die from maternal health complications than other populations, she said something like this: if you had a Porsche and you were selling this Porsche, and every time, the white woman got in it, like, it was fine, nothing happens. And every time you gave the Porsche to a Black woman, they crashed like 4 out of 10 times. Would you then go to that dealership and want to buy that car? And the point was that if health inequities exist for some, then they actually exist for all. And I appreciated that analogy because instead of equating things to numbers, percentages, and so is more likely to die than so, it was really talking about would you want to get in that car? Would you want to, go to that hospital? Would you want to give birth in the US? And I think that's the lens that we need to think about it, instead of focusing just on the marginalized populations themselves, but thinking about this as a societal problem as a whole. Because if no one's safe, or, if one group isn't safe, then no one is truly safe. So
I think
interesting, and I'm gonna,
Thank you for that. I think that's really well framed. We could also look to the past couple of years of COVID to just understand how weaknesses in certain elements of our communities or our systems really affect us nationally and globally. Would anybody like to briefly add to that, just while we're on the topic of, kind of where we're coming from, perhaps?
Absolutely. That's a great way to start, because I think so. Let's take the analogy a little bit further. And let's think about the fact that what if someone designed the car that a Black woman was getting in to crash, with intention, that there are actors and people that design the systems and gatekeepers of the systems that have assigned value, that also includes a calculus that folks may die or suffer or have their labor exploited or their lives exploited. And so the opportunity when we identify these policies, practices, procedures, and people is that we can change it. Right. So we can change the designers, we can change the policies and the practices. And so I think a lot of times when we have this conversation around inequity, disparity, and justice, it gets a little soft. It gets a little, people didn't really mean to actually, we're seeing in history and politics right now, folks actually mean it, so let's just lean into that. And we haven't said racism yet. So racism, let's just go ahead and get the first one out of the way in terms of why that car was designed to have that, if we're going with that analogy. But just that is a little bit of backstory to add in, and take a deep breath, everyone, because we're going in.
Thank you so much for that. KP or Ivelisse, would you want to add anything to this part of the conversation?
I think everything that's already been said. I think the historical piece, the way it was designed, that we continue to design, and I think we're going to touch on this, we continue to innovate on a fundamentally broken system. But I also think that there's a big distinction too. I think when we look at the inequities rather, we focus a lot on the people, right, who are real lives, right, that are harmed and dying and all the things that we see. There's also a piece too where it's also the providers as well. And so when we look at how the system was designed, it's actually designed to cause harm, and we can go through this a little bit, but it's been harmful across the board. So when we look at, not only do we look at, the outcomes of patients, and also the workforce, the providers who are leaving en masse, and the inability then to, provide care, I think it impacts us in all the ways, so.
Yeah, I just echo everything said. And there's a friend of mine, her name's Dr. Veronica Gillespie Bell. She's the head of women's health at Ochsner Health System in Louisiana. And I asked her the question about what we're talking about, like what is the driver of these worse maternal outcomes? And she shared something that corroborates what everyone's saying, which is basically the way they improved maternal health outcomes at Ochsner was through what they called implementation science. And so I asked her, what is that? She said, all that is implementing what the science says to do. So in other words, what my colleagues are saying is, for the reasons that we know, racism, a lot of times people don't want to use the word, they want to say implicit bias or something else, but because of racism, implicit bias, other isms, the things that we scientifically know work don't get implemented equally for everybody, right? And I think that was just powerful for me to hear that it was that simple. If we just implemented the standard that science tells us works for everybody equally, the outcomes would be the same, right? So, I mean, I just, that came to mind as I'm hearing my colleagues, and I just wanted to share that.
I guess just before we leave this topic, I'll add one thing. Through a number of conversations with my friend Jamal Miller, who some of you may know, he really talks a lot about social determinants of health and how, health impacts education and impacts, career, earnings, life, etc. I saw something on social media about a teacher acknowledging that obesity in our classroom affects learning. Those desks, that the chairs and the desks are attached, they're kind of that single unit where certain students can't actually fit into it, and therefore they're unable to kind of enjoy their school day. I just want to acknowledge that, we're bringing up little vignettes about maternal health, etc. But if we take a step back and look holistically, this is a pervasive issue, and one that obviously desperately needs dialogue and attention. And so I think with that as our backdrop, we'd love to really now dive in. Our topic is about restorative justice, and perhaps some kind of, interplay with intersectional innovation. And so maybe if someone feels bold enough, we can, I can pick on someone, but how do you view restorative justice? I believe you mentioned that you take it from a circular perspective. Kind of what does that term imply, and kind of how does that relate back to this topic of health equity?
Yeah, so I think fundamentally when we look at restorative justice, one, always with the history, right? We use circle practice as one way, right, of implementing that based on indigenous practice. I often tell folks, if you've never been in a circle or encountered the process of going towards restorative justice, it's like sitting around a fire, or in my house, it's always the kitchen that's very tiny, and no matter how small it is, we're all in there and we're all sharing and equitably sharing. I think when we think about restorative justice, I think there are about 3 principles. There are a few more depending on where you go, but looking at the idea of like encounter, right? That initial encounter, what were the harms, what happened? Looking at repairs, like what are we gonna do to fix the harms that have been, done? And then the actual transformation, right? And engagement and doing something different. I think there's so much that we can learn from it. I want to be really clear, like this isn't anything that I came up with. I know that we talk, think about like applying this to healthcare, but there have been folks who have done enormous, miraculous, transformative things in other industries, specifically in the criminal justice side. And I think now more than ever is where we start to see the lens between justice and health really coming to the forefront. So this idea of restorative justice in healthcare, I think for me is one where we really center the folks who have been harmed the most. The folks who have not often been heard, have been historically and intentionally silenced, and using them as the cornerstone of what the future of health looks like. There's so much that I can say, and I'm sure there'll be other questions, but I think we're at a moment right now where we are innovating, right? And we're all about innovation. But again, it's really hard to innovate on that broken Porsche that was designed, right? Not to ride the same way for everyone. And so I think we're at a moment of reckoning, and I'm so glad to have this conversation of now, what does it look like to innovate with the folks who have again, been historically harmed and silenced, with them leading the way and using that to reimagine something maybe different or really brand new.
I can jump.
Yes, please, of course. Sorry, my hand was closed. Yeah, please.
You saw the mic come off, right? So yes, and love all of that. Love all this building, because one of the things that our tribe likes to do is actually add kind of a assets-based focus to that. The fact that it's not just people who are harmed, because then we're kind of going down that road of telling the same story of Black folks being just harmed people and Indigenous folks being just harmed, versus disrupted genius, disrupted innovators. The founders of Girl Trek the other day said something about, every single person that we look at in these communities is a survivor of attempted genocide. So if we think of that as disrupted co-creators and folks who have been innovating for years and years and years, for decades, for hundreds of years, and these innovations have survived, then, we begin to flip a whole bunch of things in terms of who defines expertise, like who gets to come with ideas, whose ideas are worthy of funding without a lot of scrutiny. And so, that's one of those things that if we get to the culture of, some of the underpinning of what, was around the Middle Passage, all of the things that assigned value and assumed lack of intellect, let alone lack of genius and innovation, we can kind of flip that right away. I remember I was doing a mini press junket for South by Southwest a couple of years ago. And some of the questions that irritated me were kind of around this vibe that, Black folks don't like to be entrepreneurs. They more like jobs. How do we get them into it? I'm like, you are forgetting all of the Freedmen's towns and all of that. There's such a history of, but that's, there are a lot of people that are wedded to that idea, that have made whole careers and lives off the idea that folks of color, people who have been marginalized, have nothing to offer and don't have imagination. And that is complete and total BS, especially when it comes to our culture. So I love kind of bringing that asset-based, healing focus, genius-centric. I think sometimes we'll do a healing circle conversation on dopeness and disruptions. Let's talk about your ancestors' dopeness, and let's talk about the disruptions, and let's put it together in an exercise and come up with solutions for the future. So
I love that, dopeness and disruption. I'm going to try that at the kitchen table, see how it goes in my household. KP, putting you on the spot for a moment. I probably run the bias of viewing this topic from an American lens. You were kind enough to share a little about your family and your work internationally, specifically in the African continent. How much of this dialogue is specific to the US? Does it apply to other regions, Europe, Africa, Asia at all? I'm kind of curious if you're able to give us a lens on that.
I am actually so happy you brought that up. It's like you're reading my mind, but it doesn't get talked about enough. I mean, so I'm an American of Ghanaian heritage. Both my parents are Ghanaians. My father's from northern Ghana near the Burkina Faso border. My mother comes from a fishing tribe. And look, what we miss, and I like the whole framing of this conversation, is sometimes when we talk about health equity, restorative justice, we're kind of looking at it in a funnel, and we're not really understanding the whole intergenerational global social construct. So remember, slavery itself as a global construct was built on the construct of racism, and slavery went everywhere, right? And colonialism. So when we think about brown skin, we think about, the US has a particular history, that's a brutal history of slavery. But when we talk about Europe, if you went and you looked at studies in the UK, racial disparities exist there, right? And those racial disparities are intersectional, but they're intersectional in a different way. They're intersectional at the crossroads of national identity. So people who are, let's say, African immigrants in Europe, Blackness, right? Which has always been a construct used to separate us and to make people of darker skin be perceived as less than, be perceived as less intelligent. And so when you start to look at this globally, when I get asked this sometimes, but not often enough, I think, whether we're looking at a place like Ghana and how foreign aid moves into a place like Ghana around different topics and how that relates to inequities there, or we're talking about the US and its specific context of slavery, and the intergenerational disruption and narrative that Dr. Tony's talking about. It's a massive topic. And I think what happens is it gets so big and unwieldy that it becomes overwhelming. But I think ultimately what Dr. Tony is saying and what my friends here are saying is that there is something here about narrative and storytelling, right? Like Black people, right? People of African heritage, people of the African diaspora have incredible stories of resilience, entrepreneurship, generation after generation after generation. Part of this also has to do with the history of writing, right? So a lot of this was kept through oral tradition. And so a lot of this wasn't written as well. But I think to flip the script is to really think about narrative and to think about how these stories build across the diaspora, right? And so for someone like me, I'm sitting at the intersection of being a Black man in America. I was born in Madison, Wisconsin, having Ghanaian parents, sitting at that intersection of racism in the US and a colonial construct. Both my parents grew up in colonialism in Ghana, right? Which was driven by a racial social construct, right? So I'm so happy you asked that. I just put that frame to kind of expand our thinking. I don't have an answer, but I think there's something here about narrative in the diaspora that's very important.
Thank you, KP. I appreciate the vulnerability and sharing a little bit about your personal journey, which probably echoes, that of many others in our audience as well.
Can I frame I'd
yes,
love
of
to.
course.
I just want to frame a resource right quick
Please.
for folks, because I know we have a bunch of learned folks on here that love things. And so Esther Arma, speaking of Ghana, was just in Accra a couple of weeks ago. There's a whole conversation we can have, KP. There's a project, and you can follow on Twitter or others, called the Black Frontline, which is an oral history project framing COVID through the stories of 300 Black doctors and nurses in the US, UK, and Ghana. So in terms of narrative, global, and kind of getting a sense of what we're talking about and what it feels like in this moment. That's, so the Black Frontline, the BLK Frontline on Twitter is like a resource, and Esther Armand's book coming out on emotional justice. But in terms of how we kind of bridge on, equity, global citizenry, and innovation, right? Like these last 2 years have given us kind of an opening, I believe, to kind of really see the disruptions, the way they show up globally and locally, but also the way that innovation just arises in the face of political and social determinants. So, but yeah.
Thank you for sharing that. And love that. If there are other resources that come up as we have this dialogue, please continue to offer those. I'm sure our audience would appreciate hearing from everyone on that. Catherine, a question for you. You had referenced the fact that you work with a lot of capital allocators, and obviously as a venture capitalist yourself, presumably when you look at a system that has inefficiencies, there are opportunities to disrupt and opportunities to bring in innovation and solution. And so I'm kind of wondering, how do you approach that? Is it thesis driven? Is it market driven? Kind of from your seat and your perspective, how do you go about identifying entrepreneurs and other solution providers that perhaps are able to start the discussion of what can be better, what can be improved, and then of course the challenge of how does capital get allocated to them?
So I think you asked, is this thesis driven? Is this market driven? And maybe there was a third. So I would say it's all of the above. When I say we focus on the capital allocators, I think the check writers help drive the needle in terms of innovation. Like what gets funded typically is what succeeds, whether real or imagined, or that's fair. It kind of is what it is. And so that's from the limited partner and venture capital to the GP level to the startup level. So I'm less focused on, founders going from the idea stage to raising capital, and more looking at those who are writing the checks to fund managers, and then those fund managers to startups. And so what I think is important when working with capital allocators is for them to reflect upon what their current strategy is. Like, what do you do right now? How do you do it? And more importantly, why do you do it that way? And so let's look at your pipeline, right? If you're a limited partner and you invest in funds, how do you evaluate those funds? How do you seek out those fund managers? How do you decide what theses are aligned with your institution, whether you're, an endowment or a strategic? What does that look like for you? And if you then look at the funds that you've invested in, do those contain underrepresented fund managers or folks who have a particular thesis? And if they do, why? And if they don't, why not? And so it's really an exploratory process up to what's happening right now, and then creating tailored recommendations to those capital allocators of what they could do differently or better based on their goals. I wouldn't say it's a one size fits all strategy, but we very much are focusing on where's the money flowing and why is it flowing that way.
Thank you very much for that. You bring up a good point that I'd love to maybe shift to our next topic. This session is really kind of like the third that we've had in this series around the history of racism in medicine, and some of the impact on public health and healthcare systems. One of the things that's on my mind is, as we think about, as this you refer to it as the system designers, how do we go into the architects, those that are essentially setting up the system? I believe you had referenced some of the most affected by the system, which thank you, Dr. Lewis, for framing that in an asset-based way, our disruptive geniuses. My presumable understanding is there's probably a lot of distrust in certain marginalized communities about institutions in general, government in general, healthcare, et cetera. And so, on one hand, coming from a place of positive intention, you want to do good, you want to make outreach, you want to include people who have a distrust of that olive branch and may not feel very comfortable participating in a research or a clinical study, may not want to go through the 4, 8, or 12 years of medical school to wind up being in a place where they can architect systems. And so kind of thinking about how does the system get repaired through inclusion, but overcoming some of the genuine realities that we may encounter.
I'm happy to jump in here. So I think this comes back to, right, I think, and this is my own, right, what I see, my own analysis here. I think a lot of the times what we see are, companies, healthcare organizations, funds, pick your favorite, who do maybe some more of the performative work, right? So we care about health equity. We care about, whatever it is, we all got flags on, we all have signs up. We'll do focus groups, we'll do clinical trials, we want more diversity. And what's happening there and what we're missing is the repair, right? Or the restorative piece, right? Which, in my opinion, fundamentally comes back to accountability, right? So what are the ways in which when we are, whether you're a company, a fund, we're gonna do this and it's great. One, how are you, again, building with the disruptive geniuses? How are they there? How are you with them? But then also, how does this more than just lip service? I often say, whether it's a politician again or a company, how do we hold you accountable? What is the transparency? What are you committed to doing? I think a big thing, especially, which is nice now with the funds, is like, what is the dollar amount, right? That you are actually committing. I want to see it. We need to see it. And I think a lot of what we get to do at our work at Radical Health is we get to use these conversations, the stories, the narratives, right? And the data with the tech, right? To figure out what's happening and then actually go back with our clients and make change. And to be fair, sometimes it's small change, right? So when we let a hospital system know, right, to change their wait time, like the whole, you got to call, press 1 to speak to who, right? But that makes a big difference when we go back and say, our folks that we're working with said that this is a problem, and that's why they don't reschedule their appointments, right? They'd rather just skip the appointment and just call back and wait that 10 minutes when it's time to schedule a new appointment. Small little things, but committed, the transparency and the accountability to make sure that there's other change.
And yes to accountability, like all day, right? Because like if you, pulling from like the community organizing, community-based participation, civic engagement from that space, like there's a reason why it's not just reparations or reconciliation, it's truth first, right? And a lot of times, like folks want to kind of skip over that process and be like, how can we get people to trust us? Like, I'm so glad that like the vaccine conversation even went from hesitancy to trustworthiness to, like there was an arc there that, when people were starting with, we need to go get jabs and arms, it's like, whoa, ayo, let's, anybody on my block would be like, wait, what? I don't trust you from what happened last week, let alone what happened last year. And when it comes to innovation, when it comes to folks coming in with the new sexy things, like if you start with the truth, you may hear a lot of, okay, you're not the first person that did this. And the last time folks wasted our time, or it's to, you know, like all of the things, but like really kind of, you know, how you create space for inclusion in the process of truth tellers, and people who are willing to hear the truth. Because sometimes, like I notice, like I do some coaching of CEOs and different systems that are trying to do equity, like the process will start at, I don't know what to do if they tell me the truth. Like, I can't do anything about that. And it's like, yes, you can, you know? So how do you work through the innovations, even in the conversation, where folks get to the emotional and social parts of it, where folks are afraid of actually confronting the wrong, to just getting to truth is information, truth is history. And then how do we build from all the knowledge we have to like innovate moving forward? And so those are some of the things I see at that intersection of like really getting to, and it's gonna be a constant practice of like resetting expertise, resetting the value of who matters, resetting, even little things like making sure you're not trying to schedule an innovative conversation from 12 to 1 in the middle of the day when most of the people who are part of the community may be at work or working with, it's just, and not giving a Walmart gift card, like just really honoring the work. It's like, we know y'all are making $200K to do this. Why are you giving me like a Chipotle gift card? No shade on Chipotle. I'm just using an example, but you know how this has been. Like folks know. And so the more you can get to the truth, the more we can get to a sound foundation for accountable innovation.
I would love to draw this out a little more, because this trust issue is so important, because like they say, just in life, trust is hard to gain and easy to lose. And so if you're looking at historical injustice, you're already starting with populations that have been minoritized, you're starting at a negative balance. And I think leaders don't oftentimes understand what Ivelisse and Dr. Tony are saying, which is that the continual accountability, even if it's little things, is what starts to repair and rebuild the trust. And then once you have the trust back, or not even you have the trust back, but once you're building it back, then that gives you the platform to start to do more with these communities. But I think that gets lost sometimes, and people think it's as good as doing one thing and then being like, oh, look at what I did. This is a process. It's a process. It needs to happen over time. People that have been historically marginalized or minoritized, they're constantly watching, and they may not be saying anything, but they're watching, because that's self-preservation. If you've constantly been hammered by society, you may be sitting there and smiling, but all you're doing is watching what people are actually doing, not what they're saying, right? And so until you are accountable to doing what you say, and these populations watch you consistently make those steps, that is the only way you start to bridge the trust and get any real movement. So I think what's being said is so important.
I wanted to thank you for that, KP. I wanted to name a thing, for this particular moment that we're in now. So Edgar Villanueva, who does the Decolonizing Wealth Project and a lot of different things, was, on a panel recently where we talked about kind of this cycle of how a lot of money that went out around the racial reckoning and the murder of George Floyd, and how we're in this cycle kind of a couple of years later where people are in that, as KP just described, that hypervigilance piece, you know what I mean? That kind of, like the backlash, like one of my business partners described it as like, the undercurrent of the wave, that undertow. Sorry, I didn't grow up on oceans, I grew up on rivers. So, it's a thing. But like that whole thing where, if in our communities, the experience of the last couple of years has been folks dropping money and then coming for much more vigilance, hyper vigilance, checking all of the stuff that's just like, it's not worth it. And we didn't get a chance to even try, like there's a real kind of moment, even in this particular period, where folks are kind of watching, what's happening with funding of innovation, with funding of programs, with just what's really important and what really matters. And then who gets an opportunity to just get $1 million to do anything without proof, on a memo. Why do I have to write like a thesis statement and prove that I'm gonna solve racism in 3 months to get $1,000, with no indirect cost? But I'm just, you all know the crime. Let's just name it,
That's these are all amazing points that are being raised. I'm noticing that we have a lot of Q&A trickling in, which is wonderful too. I have maybe like one or two more last questions that I would maybe just want to pose, and then we'll definitely shift over to the audience Q&A as well. I think Dr. Lewis, you actually opened a great segue to where I wanted to go next, and maybe Catherine, you can kind of begin. I think it'd be helpful to hear of any programs or initiatives that maybe you admire that kind of understand and recognize some of the challenges that we've referenced, but nothing in life is perfect, but might be held up as role models, or might be held up as someone, something, somebody that's really doing something initiative that is moving the needle, and not to single out one out of a crowd, but just to maybe introduce something tangible that when we talk about some of the macro, we can also zoom in on the micro and say, in this community, in this project, in this initiative, here's how the tapestry of excellence is coming together. And so perhaps Catherine, maybe an entrepreneur or a program you're aware of, and then we'll turn it over to the rest of the panel for the same.
Thanks for the question, Zeev. I guess I kind of always struggle with questions like this, although I think they're completely well-intentioned, and I understand why folks like tangible examples of what's happening. I encourage people to think it's not about looking at examples of what's being done, but thinking about how can you make changes in your current practices, at least with the capital allocators that we work with. So as opposed to trying to like model yourself off of Fund X or LPY, it's more like what works for you and what's actually authentic and transparent to you that achieves the goals that you want to. This isn't me like kicking the can down the road and kind of not really answering the question. If anything, I would encourage folks to rewrote a landscape analysis on strategies that have been used to investment strategies to support Black, Latinx, and female founders in health tech with venture capital, and what just honestly what the current landscape is. So I think people tend to try to jump into solutions, and they tend to try to mimic solutions that they believe are already successful. But I want to take a step back and encourage folks to actually educate themselves about what has been done in the past, what's currently happening, and has that been effective? I think this came up earlier on the panel of talks of, oh, is it because that, let's say, Black folks in this case, they don't want to get into tech, or they don't want to become entrepreneurs, or, it's kind of equivalent to the pipeline myth. Like, there aren't enough for us to fund, so we can't fund them. And I want to say that, that's not true. So if anything, I wrote this 32-page paper with a team about these different strategies that have been used in the past. You can find it at healthtechdei.com and just kind of read it and educate yourself. I would encourage folks to make changes of things that they have that are under their direct control, and that result in direct fund allocations. So, not a program, not a webinar, cash and capital, whether that's directly to an entrepreneur or directly to a fund that allocates capital. Given I'm the VC on the panel, so that's kind of my lens. But I think that is a very tangible and very effective way to move the needle in terms of change and innovation. And it's also something that you can track.
Thank you for that perspective. A line I always liked by Oscar Wilde is "Be yourself, everyone else is taken." And so I feel like in that spirit, that is good perspective. I am hoping maybe one of our other panelists would be more comfortable, or would be comfortable naming maybe something specific. Again, not to single out one entity versus another, but maybe just to identify something that is potentially held up as either a role model or something that may have some echoes that can be internalized by any of our audience members for their own programs or practices.
I love it, Zeev. That was a big sentence right there. Like, yeah. I'd like to lift up kind of in the in the spirit of circles, right? Like, I believe like that whole like networks and things, like not so much a person, like to get out of this, white supremacy culture, we got to find one model type thing, but like we got to get in community. I'm actually loving the launch of the Congressional Black Caucus on Innovation, on Black innovation. And so I'm gonna horrify our tech people by sharing my screen. The Congressional Black Caucus on Innovation and, the Black Innovation Alliance, where you can join and kind of learn about best practices and kind of just get in community with folks who have different kind of understandings of all of the things we've been talking about in terms of historical challenges, but also people who have been, building and funding and victories. And then when you get in with the Congressional Black Caucus, and this is under the leadership of Representative Stacey Plaskett, the dope one that people generally know from the impeachment kind of part one and all the different things, like you can get into policy or ledge or, creativity. So I think, signing up or getting involved and even just seeing who's following, we can build this ecosystem, of innovation where you can find, your unique and special part in this moment. So.
Thank you so much for sharing. That was awesome. I didn't even know we could share screen. I feel like I need to get my tech tools a little bit more handy for the next one. Ivelisse or KP, would you care to add anything to that question in terms of a specific or tangible program that we just want to, lift up in the moment?
Well, I just want to mention even just the work of Dr. Aletha Maybank and the AMA's Health Equity team. Ivelisse is on this Innovation Advisory Board, and there are many people who have been involved in, I think, and kind of channeling Catherine, let's talk frameworks. So if we're talking about systemic racism in a space, then pointing to one example doesn't really get us there. We need frameworks. So the AMA has developed some really amazing frameworks around everything from language. So they have a narrative guide. How does language matter? Like how we talk about these things, the language you use, all the way to what are frameworks that groups can use around their work, right? To be authentic. Thank you so much for sharing that in the chat. So I think there's just a number of groups. I mean, really the AMA, I think, has been at the forefront of this work, and some others that are giving the frameworks that could allow each group to be intentional and authentic to themselves, as Catherine was saying about how they design for these challenges.
But I'll echo, thank you, KP, for taking my plug. I think also that is like, I like to look at, whether you're in healthcare or social innovation, I always like to look, Issa Rae says this, right? Don't look up, but look to the side, or, don't try to build going up, build to the side. And I'm sure there's a bunch of these derivatives on that. But I think the reality is there are often people, organizations who are doing things that you didn't think are possible. And I would challenge, like, for the investors, for the funds, for even, whatever role you're in, if you're in a position of power and you feel like there's a feeling of, no, I don't think that's possible, or like that won't work, I often say, like, just dig in a little bit right there, because and it's not necessarily tangible or tactical, but I think that that's where I like to spend my time. The minute I have this isn't going to work, let's just sit in there. Why? Ask and approaching it with a posture, I would say this, of curiosity. So whenever Tony said earlier, like, lean into the truth. Whenever it feels a little uncomfortable, that's an opportunity. So whether you're doing that personally at the dinner table, structurally, at work, lean into that a little more. And I think that's one of the guides for me.
Awesome. So my last quick question, and then I'll dive into some of the audience questions. We invoked something that the AMA obviously feels very strongly about in terms of the In Full Health Initiative. And so if you're not familiar at home, the Center for Health Equity inside the AMA spent a year working with a number of other entities. I think it was 14 collaborators total, really representing the health equity and innovation space. They published this, amazing guidebook, an amazing set of frameworks. And to me, one of the things in kind of the focal areas is, at the end of the day, how do we ensure that the solutions and the innovations do create health equity, that they actually kind of achieve the outcomes? And so just wondering if anyone is able to maybe take a stab at that kind of maybe ties a little bit of the effort and dialogue that we've referenced so far. We understand there's a problem. There's, solid examples of people with positive intention. But how do we ensure that when it's all said and done, we are making a dent on this topic of health equity? And so wondering if anybody wants to address that, and then we'll shift over to a few of the audience Q&A.
Maybe I can kick off with some work that we've been doing in Colorado. So as mentioned, I'm the chair of the Colorado eHealth Commission. And what that does is govern health technology for the state. So that's everything from how data is shared. So a lot of the issues during the pandemic around COVID-related data and race and other types of information being aggregated and being shared publicly to our health information exchanges, all of that sits within the eHealth Commission. So one of the things that we started working on, and when I came in as chair, I really wanted to focus on is how we understood health equity in our state. And the way we approached that was to look at our health IT roadmap. So that is the policy document that guides all work we do and all funding. And we did a refresh of that health IT roadmap, bringing in the principles of health equity. So we then brought in tools such as the tools being created by the AMA and had presentations to educate the commission on what equity looks like, how to infuse that into the policy. If you infuse it into the policy, it shapes the resources, right? And I'm happy to say that the eHealth Commission, we're actually going to become the first state government agency to adopt these in-full health principles into our policy work. Right. So I think that's an example of where you can get the conversation right at the policy domain. And there's one thing that I have to acknowledge, which is that when we looked at our rural populations in the state of Colorado, there's definitely a sense that health equity was purely about restorative justice and racism. And I had to really get people into an and mindset. Because we're talking about racism and that racism exists and it's a problem, we're not saying that rural health isn't a problem. We're saying and, right? And people wanted to immediately shut down and not have conversation. And I found that once I was able to support the stakeholders in reframing definitions about what health equity is about and intentionality, that allowed us to get to common definitions that we embrace into the policy document. So now we're starting to operationalize those things, but we couldn't do that until we got that common alignment and that embedding in the policy.
Maybe just building on that and tying in an audience question. There is interest in understanding perhaps what the public sector can be doing differently to help, specifically to either spur innovation for equitable health or even just improving trust. So curious if anybody maybe wants to take a stab at a public kind of sector lens on this question.
Oh, this is one of my favorite things. I think, you know, I want to define, this is the restore, what does public sector mean? I would love more nuance and details to make sure, but I'm going to shoot a shot here that when I look at the public sector, and we'll just call it, I'll say this, employees and employers, that dynamic, I think that's one of the early easy ways that folks can make some differences. A lot of the stuff that we get to see in our work with employers, right, are we have folks who are like, we love health equity, we're here, we're for it. And sometimes these are healthcare organizations, sometimes they're not. And when you look at then their, you know, maternity leave, paternity leave policy, it ain't it. When you look at sometimes, you know, we had one client who brought us into some work, and what we found out were, you know, the contractors who were cleaning the offices and working in the food service, they had a different health plan, entirely different than the organization. And so these are small, I mean, they're small, but also really big things. So I often like to look at for public sector, wherever you are, let's just take a look at, you know, what your access to reproductive health policies are, what your sick time, we can look at a lot of things there. And I think also, you know, this is one of the things I often say, this idea of like health fluency, the idea that there's many pieces involved that can start anywhere, you know, can start in sectors outside of health, can start anywhere. But I think that that's like an easy way to begin. I'm curious for everyone else what your thoughts are too.
Co-sign on a great way to begin with the workers. So like I am a labor union, like multi-generational person. Yeah, absolutely. Raised by 2 generations of union teachers. And for a while was president of a doctor's union and then chair of a healthcare union with 1 million members, of which several were like, you know, public sector. And so if you reach out to even, you know, constituency groups like the A. Philip Randolph Institute or the Coalition of Black Trade Unionists who have represented Black workers here and around the globe for CBTU for decades. And some have labor management partnerships around, everything from contract bargaining to innovation. Like those might be places where you've got community, you've got folks like kind of in the middle, who can speak to kind of the intersections of the work, the workers, the communities they serve, and have, at its best, union community organizing is a collective group of folks who can speak up. Look at the Amazon workers, right? And so, yeah, shout out to labor and all of that public sector. And it's interesting because, talk about, KP, talk about things that are different here versus other countries. Like, in other countries where the healthcare system is public, then you've got, all healthcare workers kind of in that space versus this kind of public private weirdness that we have per state over here. And another thing to consider, Zeev, in terms of even entering that question, like public sector per state and who decides where funding goes, who has a voice, what matters is very different. And so this is why I go to the ground, get the expertise, ask the questions, get the truth and build on it. But it's really important. So thank you for that.
I'm going to go to the audience Q&A for one more open question if someone feels they want to field this one. Thank you to Ashley for asking. How do we get health system and institutions to value what marginalized communities value instead of only centering their values as they evaluate innovation and digital health solutions? I think that ties to a few points that we raised earlier. Perhaps someone wants to address that singular question, and then we'll begin maybe wrapping up our conversation today.
My mind went to two things and anyway, part one, follow the money. So unfortunately, it's unfortunate, but even to what Dr. Tony is saying, you look at the structure of our health system and how it works, seems that money is the thing that motivates people. So at the end of the day, if you can tie equity to money, because sometimes what's happening is, look, we have to say it. All these groups are hiring chief health equity officers. They have no mandate. These are some of our most talented people of color. They go in, they have no budgets. The CFO doesn't actually believe that what they do drives bottom line, right? So then you have all these chief health equity officers that are being hired, but they're not really being positioned to influence those systems in a way that is equitable in its approach. So this is just the truth. I'm just going to say it. So there's like a money issue. Yeah. And there's these CFOs that are sitting in these organizations, and they're the quiet one in the room that doesn't necessarily believe that doing this work influences the bottom line. That's issue one, right? So issue two to me is about the people, right? So I want to hear from our colleagues, but if we have more of these folks that we're talking about, historically minoritized populations in the room, in decision-making roles and influencing resources, you will see things change. So these are just the two things that are on my mind, like right out, it's kind of knee-jerk reaction, but I'm curious what my colleagues think.
Yeah, I'm apparently as good as a moderator as I thought I was doing. We're just at the conclusion, and I wish we had another half an hour to keep going. I'm going to reserve moderator's prerogative for one last very, very quick question. Ivelisse, we're going to start with you. I know you might need to duck right at the top of the hour. Super fast from our panelists, ending on a positive note. If you could make one wish looking kind of, 2, 3, 4, 5 years into the future, what would you wish on the topic that we're talking about? All of our panelists will answer that, and then I'll get us wrapped up in 60 seconds. But Ivelisse, if you don't mind, a wish for the future.
My wish is that I don't exist. The company and the work that I have to do does not exist, and that the energy spent talking about equity can be poured into creativeness. Ashley Wisdom did a wonderful talk recently talking about the time that's spent and wasted fighting for just to be seen. So would really love to not have to do this anymore.
Amazing. KP, a wish, please.
I wish that we see those incremental movements towards trust building in the system, and that they're continuous.
I appreciate that wish. Catherine.
Oh, I would like us to hold capital allocators accountable and have them be more transparent in the way that they spend their money.
Thank you so much. And Dr. Tony.
I'm gonna go with abundance and joy, and that this conversation becomes more the norm than the exception.
It's a wonderful wish. And so with that, we're right at the top of the hour. Just summarizing a few takeaways that I heard. We talked about accountability. We talked about truth. We talked about dopeness and disruption. We had an amazing session. I want to extend just congratulations and admiration and flowers to all of the panelists. You guys were just incredible. Thank you to the audience for all your Q&A. Really want to acknowledge Olivia and the Social Innovation Summit team, and of course the American Medical Association and Dr. Maybank for really setting the tone nationally in terms of this important dialogue and creating a space for us to have this discussion. This session will be recorded in case people want to kind of follow back, and presumably all the panelists would be happy to hear from you through media or social media if you want to connect and follow. So thank you so much again to everybody. This was a great discussion. KP, I wish we had a little bit more time right at the end. I would have gladly taken a half an hour to an hour and continued, but perhaps in person in the future. So thank you guys so much again. Have a great rest of your afternoon.